First article is a review article which shows how the exercise intervention affects scapular position and motion in an individual with scapular dyskinesis. In its intervention, multimodal, which combines more than two methods, such as manual therapy with exercise or taping with exercise, are all excluded. Other criteria follows the general common ground of the studies. There were 8 studies on 3-dimensional studies. Half of them evaluated individuals with subacromial impingement syndrome, which is SIS, hereinafter, and the other half was asymptomatic individuals. Among 4 studies with SIS, 3 studies found significant effects on scapular motion. The other 4 studies without symptom, 2 studies reported significant effects of exercise. A risk of bias must be considered. There were 12 studies regarding 2-dimensional scapular motion evaluation with exercise intervention. 3 among 4 lateral scapular slide tests showed significant effects with and without SIS. Total scapular distance evaluation with asymptomatic individuals found controversial result. So one by one has different result. Radiographic analysis, McClure's classification for asymptomatic individual found significant effect of exercise. Scapular position measurement on the horizontal plane was also reached positive exercise intervention result. Total 10 articles were covered. With fast scoring, 3 studies showed significant improvement on pain with exercise, while the other one found it improved with movement. It wasn't the static result. Other 4 studies assessed the pain with shoulder pain and disability index, and all 4 studies got significantly positive results. Only the pen shoulder score did not reach any change. Well, it can be easily found that the design of the study can be led to a completely different results. Proper test design is absolutely important to reach the goal of the study. So for my own study, it is assumed that it might be my result may not be reached to what I expected, not because my hypotheses were wrong, but the test itself, test design wasn't is not proper. So I may dig into more test design to clarify the connection between shoulder function and subclinical neck pain. Next article is about the weakness of supraspinatus and infraspinatus in overweight athletes who has the scapular dyskinesis, and the strength of those 2 muscles were assessed before and after the restoration of scapular musculature balance. For the clinical assessment, scapular dyskinesis was assessed by Dr. Kibler's method, which categorized into 4 types of scapular motions. Supraspinatus test was done by empty Ken test, and the strength was measured by dynamometer, while the infraspinatus strength was tested by the infraspinatus strength test, which is IST hereinafter, and the strength was assessed by dynamometer, same as empty Ken test. Rehab was scheduled for 6 months, including lower and middle lat serratus anterior, rhomboid exercises, and includes the passive posterior shoulder stretching as well. The results showed that all the figures were improved after 3 months, and all those numbers were statistically significant. The author claims that the position of the protracted scapula disturbs generating maximal strength of rotator cuff's internal and external rotation forces. By that, biomechanically, scapular dyskinesis leads to the weakening of the rotator cuff, as scapula, which is the base of the origin, is unstable. And the shoulder impingement syndrome may causes pain on the shoulder, which again inhibit the rotator cuffs. So this gave an idea that the strength of rotator cuffs can be a link between the scapular movement and the neck pains. Last article is the strength profiles in healthy individuals with and without SD. For the background, there are controversial studies exists regarding scapular dyskinesis and its relation to upper extremity injury. To clarify it, isometric strength of the shoulder complex between healthy individuals with and without scapular dyskinesis were measured. Participants with any positive answer on Part Q test were disqualified. To identify the SD, McClure's definition was used, which are scapular winging, dysrhythmia, or both of it. Manual muscle test was done by make test rather than the break test. Strengths are normalized by averaging the maximum forces of the 3 trials and dividing by body weight. With or without SD did not significantly affect the strength. Only the between muscles strength, so the muscles and comparing the muscle with the other muscle strength were significantly different. Strength ratio did not show any significant differences between any of the groups. However, this study provides interesting idea about comparing strength ratio between pair-matched muscles. To be clear, the result of this study does not mean no relationship between the prevalence of SD and shoulder strength. So still, there are connection between SD and the shoulder strength, or even with the pain or dysfunctions.